This 2D diagram provides an overview of disorders of consciousness as a taxonomy. Cognitive function is represented on the horizontal axis, with total functional loss on the left-hand side and normal cognitive function on the right-hand side of the diagram. Motor function runs vertically from total functional loss at the bottom of the diagram to normal motor function at the top. As can be almost immediately appreciated, the interrupted red line, which indicates a loss of motor function, can hide a wide range of cognitive capacities. If we look at each diagnostic category as laid out on the diagram, we can begin with coma in the lower left-hand corner. Coma is unarousable unresponsiveness and represents no cognitive function. Vegetative state differs only from coma with eye opening. Otherwise, vegetative patients show reflex movements only and do not show evidence of purposeful goal-directed motor activity. A gray zone between the vegetative state and minimally conscious state exists, in which some patients have complex reflex behaviors which are not contingent on environmental stimuli. The minimally conscious state spans a fairly wide range. Patients who have some evidence of awareness through visual tracking or auditory localization may just make the transition from vegetative state to the minimally conscious state. At the upper boundary of minimally conscious state, patients have to reliably communicate 6 out of 6 responses accurately to environmental questions, such as, am I clapping my hands or pointing to the ceiling? The gray box here indicates the distinction between minimally conscious state patients who are able to follow commands, who are now referred to as minimally conscious state plus patients, versus minimally conscious state minus patients who do not show command following. The overall gray shading here between a coma, vegetative state, and minimally conscious state, this light gray shade, makes the point that some patients may appear to be in minimally conscious state through non-reflex movements, or vegetative state or in coma, but through functional neuroimaging technologies such as fMRI or EEG, demonstrate the ability to follow commands, thus dissociating their cognitive level from their apparent observable motor behaviors. A wider range of recovery begins to be possible when patients show signs of emergence from minimally conscious state and can communicate. Patients in the confusional state remain disoriented and unable to be tested on standard psychometric tests. Patients across the range of severe to moderate cognitive disability can be tested on psychometric tests, but fall below 2 standard deviations of the norm on some measures. Full cognitive recovery indicates the recovery of all measurable cognitive function. The locked-in state is not a disorder of consciousness, and the locked-in state is only recognized when consistent goal-directed functional movements above this interrupted green line are present. Otherwise, patients may be in a complete locked-in state or indistinguishable from patients in minimally conscious state. In fact, patients across the entire range may be indistinguishable in terms of their level of cognitive function. These ambiguities are important because distinctions as we move from left to right in terms of prognosis and natural history are increasingly clear in the literature.